following podcast is part of a certified educational activity titled Ahead of the Immunotherapy Curve in Head and Neck Cancer, Preparing for Expanding Immune Options in Locally Advanced and Recurrent Metastatic Disease. Access the entire activity and complete the post-test at peerview.com/RMT860. Downloadable slides and practice aids are also available.
Alrighty. Well, welcome everybody to tonight's talk, Ahead of the Immunotherapy Curve in Head and Neck Cancer, Preparing for Expanding Immune Options in Locally Advanced and Recurrent Metastatic Disease. Thank you all for coming. My name is Lindsay Toolings. I'm a head and neck medical oncology nurse practitioner from Smilow Cancer Hospital at Yale. And I'm joined by my colleague, Dr. Arti Bhatia, who is a head and neck medical oncologist and assistant professor of internal medicine at Yale. And then Mital Daria, who's also a head and neck nurse practitioner joining us from UCLA. So goals for today. During this symposium, you will learn that evidence supports the integration of immunotherapy into adjuvant and neoadjuvant protocols for resectable head and neck squamous cell carcinoma. Bispecific antibodies represent a newer immune-based strategy with potential applications in recurrent metastatic disease. Multidisciplinary team workflow and flexible planning with immunotherapy are essential in definitive or recurrent metastatic disease settings. And attention to dosing and safety management can optimize delivery of care with immunotherapy for patients with head and neck squamous cell carcinoma. So to begin, I'm just going to be giving you some general information about head and neck cancers and the way we manage them. And then I'm going to turn it over to Dr. Bhatia, who's going to talk about novel approaches using immunotherapy and bispecifics. And then we'll end our talk with some case presentations and dosing considerations presented by Mital. So just a brief overview of head and neck cancer anatomy to get us started. Head and neck cancers primarily consist of squamous cell carcinomas, which develop in the mucosal linings of the nose, mouth, and throat. We characterize them by the area of the head and neck in which they begin. The oral cavity consists of the lining of the cheeks and the inside lining of the cheeks and the lips, the front 2/3 of the tongue, the gums, the floor of mouth, and the hard palate. Then we have the pharynx, which starts behind the nose and leads to the esophagus. This is further subcategorized into 3 parts: the nasopharynx, the area behind the nose, the oropharynx, which includes the soft palate, base of tongue, and tonsils, and the hypopharynx, which connects to the esophagus. The larynx is a short passageway in the throat just below the pharynx and contains the vocal cords and epiglottis. Head and neck cancers can also originate in the salivary glands, which is a more diverse group of malignancies because of the many different cell types found here. These are far less common. And then we also have cancers of the paranasal sinus and nasal cavity. The presentation, location, and demographics of head and neck squamous cell carcinoma can vary according to HPV status. So HPV-related cancers are often found in non-smokers, are much more common in men versus women, are often younger, in their 50s, predominantly white, and have higher socioeconomic status and education levels compared to patients with HPV-negative cancer. These cancers are caused by the human papillomavirus, which is a sexually transmitted infection. So having HPV exposure through multiple sexual partners increases your risk. The most common location of these cancers is the oropharynx, so base of tongue and tonsil, and the most common presentation is a painless neck mass. The HPV-negative patient population is a lot more heterogeneous. The predominant gender is still male, but on average they are older, so in their 60s or above. And we see higher incidences in non-white populations, and they often have lower socioeconomic status and education levels. The main drivers of these cancers is excessive tobacco and alcohol use, but other risk factors including chronic immunosuppression, so including our organ transplant patients, patients with HIV, or anyone on chronic high-dose steroids or immunomodulators are at risk. Epstein-Barr virus is an independent risk factor for squamous cell carcinoma of the nasopharynx. This cancer occurs in higher incidences in Asian populations where this virus is more prevalent. And then occupational hazards can cause these cancers as well. So thinking about our firemen, our construction workers, mechanics. These cancers are commonly found outside of the oropharynx, and the common presentations are often sore throat, difficulty swallowing, and referred ear pain. So where do we stand with head and neck cancer today? Head and neck cancer makes up about 3% of all cancers in the United States, with estimated new cases around 72,000 per year, and deaths is still as high as 17,000 per year, according to the most recent SEERS data. This graph to the right is limited to oropharynx cancer cases, but highlights the trend that HPV-related cases are on the rise, while tobacco-associated head and neck cancer cases have been steadily declining. HPV-16 is responsible for roughly 85 to 90% of cases. And the rise in HPV cases is expected to continue for several more decades until we see the impact of the HPV vaccine, which was first approved for use in 2006 and is protective against more than 10 types of high-risk HPV. So small plug for anyone in the audience with children to get them vaccinated before they become sexually active. For oropharynx cancers, differentiating HPV status is important. It impacts staging, but also has treatment and prognostic implications. The most popular method is immunostaining for P16, which is a surrogate marker for HPV status. This is routine for all oropharynx lesions, but can be a helpful diagnostic tool for head and neck cancers with unknown primaries metastatic to the neck. Confirmatory testing for HPV genotype can also be done on pathology specimens, and some centers have started to use NavDx, which is a blood test designed to detect circulating HPV as a surveillance tool, and we do use that at Yale. So on the whole, HPV-negative cancers tend to have a worse prognosis and are less responsive to treatment compared to HPV-positive oropharynx cancers. As you can see here on this graph, the 5-year overall survival for almost all head and neck subtypes is significantly worse in HPV-negative disease. So this discrepancy has led to research that looks at intensifying the standard of care for HPV-negative disease with the addition of immunotherapy or other novel agents, while research in HPV-positive oropharynx cancers has been trying to de-escalate therapy to see if this is still efficacious and safe. Some centers, including Yale, have adapted a de-intensified approach based upon the ECOG 3311 trial, and we're now giving 50 gray instead of 60 gray of radiation to intermediate risk patients after surgery. So current therapies for head and neck cancer include isolated or various combinations of surgery, radiation therapy, chemotherapy, and immunotherapy. The management has historically been stage dependent, with therapies increasing in intensity for higher stage diseases. In general, oral cavity squamous cell carcinomas are treated with surgery unless metastatic, unresectable, or surgery is contraindicated. Oropharynx HPV-positive squamous cell carcinomas can be treated with transoral robotic surgery or radiation therapy alone for early stages, while platinum-based chemoradiation is the standard for advanced stage disease. Cetuximab, which is an EGFR-directed monoclonal antibody, is reserved for patients in which chemotherapy is contraindicated. The standard approach to head and neck cancer with surgery followed by adjuvant chemoradiation was established based upon major phase 3 trials that were conducted in the early 2000s. However, with this approach, the relapse rate is still roughly 1/3 of patients within the first year of completion of therapy, and the 5-year overall survival after adjuvant chemoradiation is still 45%. This has been the standard of care for the past 20 years, but recently that changed in 2025 when pembrolizumab was FDA approved for use in the perioperative and adjuvant setting for patients with tumors that are resectable and PD-L1 positive. This was based on the Keynote 689 study, which showed improved event-free survival in patients who received the addition of pembro to the standard of care versus the standard of care alone. And we'll talk more about this study to come in the next section of our talk. So turning to the NCC and guidelines for recurrent metastatic non-nasopharynx head and neck squamous cell carcinoma, as you will see, Pembro is approved in combination with platinum-based chemotherapy and 5-FU as first-line therapy, or alternatively as monotherapy in patients whose tumors are PD-L1 expressing. Other recommendations include cetuximab with platinum and 5-FU in patients whose tumors do not express PD-L1 or where immunotherapy is contraindicated. And there are also a variety of other combinations that are considered appropriate, including carbotaxel pembro, which we most commonly use in our clinical practice. But I think the point here is that the median overall survival with first-line pembro plus chemo is roughly only 13 to 17 months. So this just highlights the need for new and novel therapies in this space. So turning to the multidisciplinary team, this is the cornerstone to head and neck cancer care from diagnosis through survivorship. Because this disease affects vital functions such as speech, swallowing, breathing, and nutrition, head and neck cancer can be very morbid. The treatment course is also extremely grueling, and recovery often takes 2 or 3 times as long as it does to deliver the therapy itself. There are also many chronic side effects of radiation that have long-term impacts on quality of life. And the advanced practice provider really plays a key role in this multidisciplinary team, can help with symptom management, care coordination, and patient education to deliver effective, function-preserving, and toxicity-aware care. I often tell my patients that chemoradiation will be one of the hardest things, if not the hardest thing, that they will ever go through in their entire life, but reassure them that there's a large team of people who are going to help them get them through it. So this team often includes dietitians, social workers, dentists, speech and language pathologists, and physical and occupational rehab therapists, in addition to our nursing teams. Appointment fatigue, though, is very real for these patients. Therapy can take months to administer, and with the addition of neoadjuvant and adjuvant immunotherapy, this extends the course even longer. So sometimes it could be really hard to convince these patients to see these supportive care services when they already have multiple appointments per day and are coming to our cancer center for weeks on end. But what we do know is that early referrals can prevent treatment delays, and receiving treatment at high-volume centers has been shown to improve outcomes. So patient education is really essential here. One of the challenges that is pertinent to advanced practice providers in this new era of concurrent administration of immunotherapy and chemoradiation is identifying and distinguishing overlapping toxicities. And how do we expect our patients, or how do we educate our patients in a way that they can understand why they need these therapies and also what to expect? So when you do side-by-side comparisons of chemoradiation versus immunotherapy, we know that chemoradiation is much more toxic. The side effects are well established, they're predictable, and they're universal to most patients. When I counsel my patients about chemoradiation, I can tell them what to expect and almost exactly when to expect it. Side effects such as pain, difficulty swallowing, taste changes, weight loss, mucositis, phlegm production, skin breakdown, these are all very expected and cumulative throughout the treatment course. In my experience, it's much harder to counsel patients about immunotherapy because adverse events are unpredictable and there's a lot more variability from patient to patient. Talking about the mechanism of action of these drugs can help them understand the differences. And then when we look at combination therapies, we can apply what we know from the Keynote 689 study that showed only a small difference in grade 3 adverse events and no new safety signals with the addition of Pembro. So it's important to provide reassurance to patients when counseling them about this. As advanced practice providers who are managing these patients on combination regimens, it's important to think about key challenges in identifying and differentiating overlapping toxicities. If we don't make the right diagnosis or attribution to therapy for our patients, we run the risk of mismanagement and inappropriately holding the wrong drug, which can have implications for treatment outcomes, and if we miss an immune-related adverse event, result in end organ damage, which would be terrible. But it can be challenging and sometimes impossible to make this distinction. So what can we do? It's important to establish baseline organ monitoring before starting therapy. Often this involves getting a CBC, CMP, TSH, and you can also consider baseline cardiac testing in certain patient populations. When adverse events develop, you want to have a standard approach. This includes timing of adverse events relative to treatment. So are they acute? Are they subacute? Are they happening suddenly, or are they accumulating from week to week? We want to check our anatomic distribution. Is this AE in the treatment field, or is it more diffuse? And then we want to use our laboratory and imaging data to help give us clues about attribution. In difficult cases, we want to use our multidisciplinary colleagues, although I do recognize that getting patients in to see a specialist in an urgent fashion can sometimes be very challenging. And if you're ever unsure but suspect immunotherapy might be driving toxicity, it's always safest to hold. So these last two slides are just highlight some considerations for overlapping toxicity in head and neck cancer patients. It's certainly not a comprehensive list, and because of time, I'm not going to review these in great detail. But the slides are available for you to reference later on, and I'm certainly happy to answer any specific questions about this in the Q&A session. So very quickly, dermatitis. We definitely expect skin breakdown within the radiation field. This often builds over the course of radiation and heals quickly, usually within a couple weeks after stopping. Immunotherapy dermatitis is also common, though, and it may be tricky to distinguish from a chemotherapy rash, which is less common. But often topical steroids plus or minus hydroxyzine for itching works pretty well for this. Hepatitis is a little trickier. Pattern and onset is often key here. Often lower grade and more insidious onset is more common for chemotherapy. And we see this more with taxanes than we do with platinums, but both agents can do it. Whereas immunotherapy, you may see a sharp and sudden increase in the lab values. It's also important to point out that there may be other confounding factors in this patient population, like excessive alcohol use, acetaminophen use, and viral causes. So you want to make sure that you're ruling these out as well. Hypothyroidism is a very common side effect of head and neck radiation. About 50% of our patients will develop it at some point. The pattern that we usually see is typically thyroiditis early on, and then this transitions to hypothyroidism months to years after completion of radiation. We may see this sooner for patients who are concurrently receiving immunotherapy, but regular monitoring of thyroid function is standard for these patients. And regardless of cause, you want to treat the hypothyroidism when you see it with levothyroxine. Renal toxicity is very common with cisplatin. This is exacerbated by dehydration during chemoradiation and often accompanied by electrolyte wasting. You want to hydrate these patients aggressively and reserve a low threshold to switch to a chemo that's less nephrotoxic if you see the creatinine continue to rise. Immunotherapy renal toxicity is much rarer and often co-occurs with other immune-related toxicities. This is often caused by interstitial nephritis as opposed to acute tubular necrosis, which is what we see with platinum agents. So sterile pyuria or a white blood cell cast might be clues here. And then finally, pneumonitis. This one we should have a low threshold for in any patient that has new respiratory symptoms on treatment, but it may be very difficult to differentiate between aspiration pneumonia, which also occurs very commonly in this patient population. The workup for this often includes chest x-ray, oxygen saturation, and speech-language pathology referral. With aspiration pneumonia, you may see fever and or leukocytosis on labs, but even without this, it's not wrong to try empiric antibiotics to see if symptoms improve and then quickly pivot to a course of steroids if you're worried that it's related to immunotherapy. We also want to include our pulmonology colleagues here, as sometimes this can be imaging interpretation in these patient populations can be very difficult. All right, with that, I'm going to turn it over to Dr. Bhatia.
Thank you, Lindsay. Good evening, everyone, and thank you for joining us tonight. I will be reviewing some newer expanded use of immunotherapy in head and neck squamous cell cancers, as well as talking about some newer agents in development in this disease. Oops. Okay. So we know that anti-PD-1 agents have changed the treatment paradigm for patients with recurrent and metastatic disease. They have been our go-to first-line treatment options for these patients for several years now. And because of our experience and their efficacy in the recurrent metastatic setting, investigations have been conducted for patients with high-risk locally advanced disease as well. And that has recently led to 2 large practice-changing trials that we will talk about next. Okay, so in other diseases and other tumor types, the addition of neoadjuvant and adjuvant immune checkpoint therapy to standard of care curative approaches have changed outcomes. And Keynote 689 was a trial that tested the strategy in recurrent and metastatic in locally advanced squamous cell cancers of the head and neck. This was a large randomized phase 3 trial. It enrolled almost 700 patients. These patients had stage 3 or 4A resectable tumors of the oral cavity, oropharynx, hypopharynx, or larynx. And these patients were then randomized in a 1:1 fashion to receive either standard of care treatment, which today is or used to be surgery, followed by risk stratified radiation or cisplatin and radiation in the adjuvant setting that was based on pathologic features. Or they were randomized to the experimental arm, which was 2 doses of neoadjuvant pembrolizumab first, and then they went on to surgery. And then received risk stratified radiation or cisplatin radiation, concurrent with 3 doses of pembrolizumab. And that was followed by 12 additional doses of maintenance pembrolizumab given every 3 weeks. So the total treatment duration was a year. The primary endpoint was event-free survival by blinded central review, and the key secondary endpoints were major pathologic response rate at the time of surgery, overall survival, and safety. And as you can see in these Kaplan-Meier curves, at the 3-year event-free survival was significantly improved with the addition of pembrolizumab. The hazard ratio was 0.73. The p-value was significant at 0.008. And although overall survival data were not mature at the time of this first interim analysis, you can see that there is a trend to improvement with the addition of pembrolizumab. So the blue curve is riding higher than the orange curve. The blue curve was the one with pembro. Nivo post-op was another randomized phase 3 trial, and this tested the addition of nivolumab, which is another anti-PD-1 agent that is approved in the recurrent and metastatic setting. This agent was added to standard of care adjuvant treatment, so post-op, and with an intention to see if this can help improve on our current standard of care. So standard of care in this disease, which is cisplatin and radiation, has not changed in over 20 years. And despite maximum multimodality treatment, these patients get surgery, morbid surgery, followed by radiation and chemo. 40 to 50% of these patients will still develop tumor recurrence. So the goal was to see if we can improve on that. So this trial enrolled about 680 patients. These patients had resected tumors, so they had stage 3 or 4 resected tumors of the oral cavity, oropharynx, hypopharynx, or larynx. All these patients had high-risk pathologic features at the time of surgery, which in head and neck tumors is defined as positive surgical margins or positive extracapsular extension in the cervical lymph nodes. And these patients were then randomized to receive the current standard of care adjuvant treatment, which is 66 gray of radiation, concurrent with 3 doses of 3 weeks cisplatin. So that's the high dose, 100 milligrams per meter square given every 3 weeks. Or they received the experimental arm, which was a lead-in dose of nivolumab, followed by the same cisplatin and radiation, but concurrent with 3 doses of nivolumab, and then again, maintenance nivolumab, 6 doses given every 4 weeks. And the primary endpoint here was disease-free survival. And again, as you can see here, the 3-year disease-free survival was significantly improved with the addition of nivolumab. It was 63.1% with the addition of nivo versus 52.5% for the standard chemo radiation. The hazard ratio was 0.76, did not cross, the confidence interval did not cross 1, and the p-value was 0.03. And adding nivolumab to chemo and radiation also decreased the risk of locoregional relapse. So again, you can see it in this curve, and the hazard ratio for this endpoint was 0.63, also making it significant in favor of adding nivolumab. So together, these two trials really demonstrated the safety of adding anti-PD-1 agents to standard of care chemo and radiation, whether it be in the neoadjuvant or adjuvant setting in patients with head and neck tumors. Patients definitely spend extra time on treatment than they would with standard treatment. They also have to be counseled on the possibility of immune-mediated adverse events, which will obviously occur with the addition of anti-PD-1 agents. But really the key point was that acute treatment-related toxicities during chemo and radiation did not significantly worsen with adding anti-PD-1 agents, and our ability to deliver the chemo and the radiation in a timely fashion was not compromised. So moving on, I'm going to talk about some newer agents now which are in development yet. They're not standard of care, just to be very clear, but carry potential to improve responses to our currently approved standard of care anti-PD-1 agents. Okay, our first up is petosemtamab. This is a bispecific antibody. It targets EGFR and LGR5, which is a protein that's expressed on cancer stem cells. And this drug has three distinct mechanisms by which it works. So it blocks EGFR ligand binding, which is something similar to what cetuximab does as well. But in addition to that, it also helps with internalization and degradation of the EGF receptor in LGR5 positive cancer cells. And it can mediate immune cell activation by enhancing antibody-dependent cellular phagocytosis and cellular cytotoxicity. So it kind of is a much better improvement on cetuximab, if you will, because it has an additional protein target. So efficacy outcomes from a single-arm phase 2 trial, which evaluated petosemtamab in combination with pembrolizumab in patients with treatment-naive. So this was a first-line population of PD-L1 positive, recurrent, and metastatic head and neck squamous cell cancer patients. This trial was, updated results from this trial were presented at ASCO in June this year. And in this cohort of 43 evaluable patients, there was a confirmed objective response rate of 63%. So just to give perspective, this compares very favorably to the 15 to 18% response rates that we see with pembrolizumab monotherapy in this population. And responses were seen across P16 subgroups, so both P16 positive and negative patients responded to treatment, and across PD-L1 subgroups, so PD-L1 low and PD-L1 high benefited from the addition of petosemtamab. The median progression-free survival for this cohort was 9 months, again comparing very favorably to the 2 months we see with pembro monotherapy. And at 1 year, 80% of patients were still alive, also comparing very favorably to pembro monotherapy. So preliminary results, small patient cohort, but very exciting, very promising. And there is a two phase 3 trials actually ongoing with this agent. One is in the first-line setting in combination with pembrolizumab, and the second trial, also phase 3, is in the second-line or third-line setting. This is after pembro and chemo exposure, so as a monotherapy, and those results are eagerly anticipated. The second agent is ficerafusp alpha. This is also a bispecific antibody. It targets EGFR and TGF-beta. So it has a separate co-target from petosemtamab, but the EGFR backbone remains the same. And this agent works by inhibiting the immunosuppressive effects of TGF-beta in the tumor microenvironment, but restricting it to the tumor microenvironment because it has an EGFR-directed approach, which is present or overexpressed on tumor cells. This agent can also enhance the ADCC effect that cetuximab possesses or petosemtamab possesses as well. It helps promote interaction with natural killer cells, other immune cells. It helps prevent epithelial mesenchymal transition, which can help epithelial tumor cells invade into the interstitium and cause metastases. So that's the way this drug is kind of like an improvement on cetuximab again. And these are efficacy outcomes also from a single-arm early phase trial. This trial gave ficerafusp alfa and pembrolizumab in combination to patients with HPV negative only, PD-L1 positive, treatment naive, recurrent and metastatic disease. And in this cohort of 28 patients, there was a confirmed objective response rate of 54%. Most of these patients, as you can see from the waterfall plot here, experienced very deep and durable tumor shrinkage. So median progression-free survival for this cohort was almost 10 months. Median duration of response was 21.7 months, and median overall survival was 21.3 months, which if you consider our current baseline from Keynote-048, which was the trial that led to Pembro's approval, the median overall survival there was about 13 to 14 months. So again, comparing very, very favorably early results, but this was a high-risk population. And there is a phase 3 trial ongoing with this agent too. It's called Fortify Head and Neck. That's enrolling treatment-naive recurrent metastatic disease. And our last bispecific antibody is amivantamab. This also co-targets EGFR and MET. A lot of patients with HPV negative disease we know have resistance to cetuximab because of alternate pathway signaling, usually through MET amplification. So this drug, in addition to blocking signaling through the EGFR and MET pathways, again, can also help recruit immune cells into the tumor microenvironment with an ADCC effect. And this drug is already approved in EGFR mutated non-small cell lung cancer. So there are approvals based on phase 3 trials in EGFR exon 19 deleted tumors in combination with lazertinib, as well as in combination with platinum and pemetrexed. It's also approved in EGFR exon 20 inserted tumors in combination with carbopemetrexed or as a monotherapy. A key point of difference, the approval in lung cancer is for an intravenous infusion of amivantamab. The drug that's being currently tested in head and neck squamous cell cancers is a sub-Q version of the drug. Common toxicities that we've seen with this agent include acneiform rash, kind of similar to cetuximab because of its EGFR backbone. It can also cause paronychia. There can be administration reactions. Thromboembolic events, especially when given in combination with lazertinib, and hypoalbuminemia is a usual class effect that we see with MET inhibition. So the Origami 4 trial was an early phase trial that was conducted in patients with recurrent metastatic head and neck cancers. There were multiple cohorts on this trial, all using different combinations of amivantamab. Some were monotherapy, some were with pembrolizumab, some were with chemotherapy. And cohort 1 of our Origami 4 was reported earlier this month at ESMO. It was also a poster at the JADPRO conference, I think today or yesterday. And this cohort enrolled patients with pan-refractory HPV negative tumors. So these patients had already received immune checkpoint therapy. They had already progressed on platinum-based chemo. And 38 patients were included in this efficacy population, all received amivantamab monotherapy, and the objective response rate for this population was 45%. The clinical benefit rate was 76%. Again, comparing very favorably if you think that cetuximab is the standard of care here, and after immune checkpoint and chemotherapy, the response rate is about 20%. So this, in a way, more than doubled that. Many of these patients, again, had very durable responses. So if you look at the median progression-free survival, it's about 6.8 months. This cohort had a median follow-up time of 8.3 months, and the median overall survival was not reached at that time point. So these are very meaningful numbers for this very poor prognostic and very symptomatic patient population. And on the right, you can see some representative images of tumor responses in the lungs there. from patients who were enrolled on this trial. And cohort 3 of Origami 4 was a smaller cohort. This was 11 patients. Again, HPV negative, refractory to immune checkpoint and platinum-based treatment. And these patients received amivantamab and paclitaxel. This cohort reported a response rate of 64%, so adding chemotherapy helped with the response here. Again, you can see the waterfall plot. Most patients had a treatment response. Amivantamab is now going to be explored in a phase 3 first-line trial. It's going to be called Origami 5. And this will enroll patients with treatment-naive disease first-line to either platinum 5-FU and pembrolizumab, which is our current standard of care, versus platinum amivantamab and pembrolizumab. Okay, so my last couple slides are going to be on some newer approaches for specifically targeted towards HPV-positive disease. I'm first going to talk about the PDS-0101. This is an investigational cancer vaccine, and it contains HPV-16-specific neoantigens. It works in conjunction, or has been tested in conjunction with checkpoint inhibitors. It's postulated to work by increasing or upregulating type 1 interferon expression, which can drive antigen processing, antigen presentation, and all this helps to generate a greater number of HPV-16 specific effector T cells. There was a single-arm phase 2 trial. This was called Versatile-2, and this tested the combination of PDS-0101 and pembrolizumab in patients with treatment-naive, HPV-driven recurrent metastatic head and neck tumors. And this trial was also presented at ASCO this year. In a cohort of 53 patients, an objective response rate of almost 36% was reported, with a median overall survival of 30 months. And based on this encouraging data, the company has moved forward with Versatile-3, which is a randomized phase 3 trial. This will enroll patients with treatment-naive, HPV-driven recurrent metastatic head and neck tumors, and they will be randomized in a 2:1 fashion to get either the combination of PDS-0101 with pembrolizumab or pembro monotherapy. And this trial is ongoing. And the second agent I want to highlight is ozuriftamab vedotin. This is an antibody-drug conjugate. It's emerging in the second-line plus treatment of HPV-driven recurrent metastatic tumors. This antibody-drug conjugate targets ROR2. So ROR2 is a protein. It's a cell surface transmembrane receptor protein tyrosine kinase. It's overexpressed in multiple tumor types, including head and neck cancers. And the uniqueness of this agent is that it conditionally binds to its target, ROR2, in a low pH environment. So that environment classically exists around the tumor or in the tumor. So because it's conditionally binding in a low pH environment, it minimizes targeting in normal tissues. It minimizes the off-target effects of the drug. So the hope is that there would be fewer side effects with this agent. There was a small trial that was reported at ASCO this year. It evaluated patients with heavily pretreated disease, so their median lines of treatment was about 3. They had all received previously anti-PD-1 agents, platinum-based chemo, and then they enrolled onto this trial. And they reported on a cohort of 11 patients with HPV-positive disease who received the Q2-week dosing with this agent, an objective response rate of 45%, and median overall survival of 11.6 months was reported. So again, encouraging data in a very pan-refractory population. And this trial is also going to open in phase 3, trying to seek registration for HPV-positive patients in the second and third line setting. And with that, I think that brings me to the end of my section. I'll hand it over to Mital.
Thank you so much, Dr. Bhatia. Good evening, everyone, and thank you for staying with us. It's my privilege to introduce our case studies for this evening with Michael. He's a 60-year-old gentleman with HPV-negative oral cavity cancer. He has squamous cell carcinoma of the right lateral tongue, slow rate of progression, stage 4A, and he has a PD-L1 CPS score of 20. So the first question for discussion is, what is the role of APs in counseling patients on biomarker PD-L1 testing. So I think it's really important as APs that we remain as educators and that patients are aware that for perioperative pembrolizumab, a CPS score of greater than 1 is necessary in order for them to be a candidate. A lot of patients are seeing commercials on immunotherapy and they'll come in and they'll say, well, I want immunotherapy. So I think we need to let them know that there are guidelines and we can discuss the data from Keynote 689 if we need to. Second question is, how do you address overlapping toxicity with concurrent immunotherapy and CRT, and what is the MDT role? Lindsay, you touched on overlapping toxicities between CRT and pembrolizumab. So the timing of the toxicity, it can actually help us delineate the cause. And the example I'm going to give is I had a patient who ended up with severe mucositis, and she was on week 6 of CRT. So she had received 2 treatments of pembrolizumab prior to surgery, and she was on her second treatment of adjuvant pembro. And she came into the office and she had severe mucositis to the point where we actually had to admit her to the hospital. And the problem was that we couldn't figure out whether this was from radiation because she'd received 6 weeks of radiation, or whether it was from, the 3 doses of pembrolizumab. So we ended up treating her with high-dose steroids alongside with analgesics, and sometimes the cause cannot be delineated. So the timing is really key as to the presentation of a toxicity, but sometimes it involves, multidisciplinary conversation with radiation oncology as to depict the cause. How do you explain perioperative immunotherapy to patients who are candidates for this strategy? I usually tell patients that the immunotherapy will sandwich the surgery. So they'll be receiving immunotherapy prior to surgery and immunotherapy after surgery. The next slide is really excellent. It really shows you the workflow, and it's something that I would even hand to my patients so I could walk them through. So at the very beginning, it's important that we test for PD-L1 CPS score. And often when patients are diagnosed with squamous cell carcinoma, it's a fine needle aspiration sample that's taken. And when we try and do a PD-L1 CPS score on it, often comes back from pathology saying it's insufficient sample. So at that point, it's really important for nurses or nurse practitioners to contact surgery and say, during resection, we really do need the CPS score, PD-L1 CPS score, so that we can make a decision on adjuvant pembrolizumab. So that's the very first piece. We do need to explain to patients that we can do the pembrolizumab up front for 2 cycles, Q3 weeks. They would then proceed to surgery. And whether or not we do adjuvant pembrolizumab or give chemotherapy really depends on whether their pathology shows high-risk features being positive margins or extranodal extension. So it's really important to discuss that with patients, because patients may not understand when they come back and they don't have high-risk features. We say, no, we're not doing any immunotherapy, we're not doing any chemotherapy. That might really phase them. So we need to sort of give them an upfront understanding that the adjuvant part really depends on the pathology result. We do need to start chemoradiation within 6 weeks of surgery, so it's important for patients to understand that. We need to explain that we'll be giving 2 sessions of pembrolizumab up front prior to surgery, Q3 weeks apart. And then for adjuvant, we'll be giving pembrolizumab Q3 weeks apart with the cisplatin for 3 doses, and then continuing with adjuvant pembrolizumab for maintenance Q3 weeks or Q6 weeks for a total of 1 year. So they understand that the treatment is long-term. So the dosing on the pembrolizumab is 200 milligrams IV. So looking at the metastatic recurrent setting, we usually treat with 200 milligrams IV or 400 milligrams IV Q6 weeks. During the actual pembrolizumab for the perioperative setting, it's at 200 milligrams IV Q3 weeks all the way through. So that's just important to note. Okay, moving on to the next case, we have Jennifer. She's a 56-year-old woman with squamous cell carcinoma of the tongue, P16 negative. She's presenting with bleeding. So I'm going to involve Dr. Bhatia. How would you approach this case?
So, we heard in the first case about how this patient has stage 4A tumor, but slow rate of progression, and we wanted to offer him perioperative immunotherapy based on results of Keynote 689. We do get into a little bit of a dilemma when we have very rapidly progressive tumors, which are very symptomatic, like in this person, if there's been a lot of bleeding, signifying that the tumor is rapidly progressive. And we know that immunotherapy alone works rather slowly. It's going to take a few weeks to elicit a response and have some clinical benefit. Some patients aren't comfortable with that approach of just giving them immunotherapy and delaying surgery, which could, hopefully help alleviate some of their symptoms. A couple options we consider in this setting is one, either proceed straight to surgery, because we know that, there is still a benefit of giving immunotherapy on the back end, like we've seen with Nivo post-op. And we can alleviate their symptoms with surgery and then bring in the immunotherapy afterwards. The second approach, for which we don't have any randomized trials yet, is to consider adding chemotherapy to immunotherapy. That is something we have done in practice too, hoping that tumor shrinkage will help with surgical morbidity and still get the benefit of immunotherapy into the patient. So those are a couple options we could consider here.
Thank you so much, Dr. Bhatia. So let's just say this patient does go to surgery and they undergo a partial gastrectomy and ipsilateral neck dissection. They're staged at P2 and 3B. They're found to have 2 out of 24 nodes positive. They have extranodal extension. They have positive margins. They have PNI and LVI present. So they have all the high-risk features. They have CPS of 10, so they're definitely a candidate for immunotherapy. 4 weeks post-op, their ECOG is excellent, their wounds are all healed, they have no metastatic disease on their PET-CT. Question is this patient a candidate for adjuvant immunotherapy with CRT? They certainly are. They have all the high-risk features, they're at the correct stage, and they have no metastatic disease on their PET-CT, good performance status. So how do you explain the post-operative nivolumab regimen to patients? I'm going to flip to the next slide so that you can see this. And the Nivo post-op study included a lead-in dose. So they would go to surgery, and within 2 weeks, they would receive a dose of nivolumab at 240 milligrams IV. I'm not sure how this would translate in practice. A lot of patients are still recovering from surgery, may not want to come in for to start immunotherapy. There could be a lot of anxiety around that. So it's going to be interesting to see how this plays out in practice. With regards to the nivolumab later on, it's given, again, with the CRT therapy, it's given Q3 weeks at a dose of 360 milligrams. And then it's given adjuvantly after that. We've got a 4 to 12 week break. So if patients feel after CRT they need a break and they don't want to have any treatment, they've got 4 to 12 weeks to start the adjuvant nivolumab alone. And for that, it's a 480 milligram dose, Q4 weeks, for 6 doses. So for nivolumab dosing, again, the lead-in dose is 240 milligrams IV, or it could be 600 milligrams sub-Q. The lead-in dose is 240 milligrams IV, and then it's given Q3 weeks times 3 times with CRT at 360 milligrams IV, and then given at Q4 weeks times 6 at 480 milligrams IV. There is sub-Q dosing for the recurrent metastatic setting at 600 milligrams Q2 weeks or 1,002 milligrams Q4 weeks. So the next case is David. He's a 62-year-old gentleman with HPV P60 negative recurrent metastatic squamous cell carcinoma. CPS is greater than 1, and he has an ECOG of 1. So he's had prior CRT for laryngeal carcinoma and is now found to have lung and bone metastasis. We know also that he has a great family support and is open to pursuing additional options, including clinical trials. What is the prognosis for this patient with HPV-16 negative disease? Well, we know from Lindsay's slides earlier that those with HPV negative disease have a worse prognosis. What are the standard options to consider? Dr. Bhatia, what do you think?
So our currently approved standard options for patients with recurrent metastatic disease is either pembro monotherapy or pembro in combination with platinum-based chemo. In someone who has a CPS positive score and if they have relatively small volume asymptomatic disease, you could consider pembro monotherapy, or you could consider a combination with chemo backbone. Both are approved choices.
Thank you so much. Would you consider this patient a good candidate for a clinical trial? That's a great question. What makes a good candidate for a clinical trial? So we often look in studies at inclusion and exclusion criteria, but I think it's really important to look at the patient themselves and see what their attitudes are to a clinical trial. Some patients will say, no, I don't want to be part of a clinical trial, I don't want to be a guinea pig. So the attitude of the patient towards the clinical trial is extremely important with regards to whether or not they're actually going to be compliant. The other issues are financial considerations and time. Do they have enough time to make all the appointments involved? A lot of studies have have lots of biopsies, may have a high rate of imaging that's needed. There's a lot more appointments. Do they have childcare that can cover them when they're actually at appointments? So those kind of logistical considerations need to be assessed. For this particular patient, looks like he's got a good family support network, so maybe he can have people cover for him, whether it's childcare or whether they can drive him to appointments. And he seems to be interested in clinical trials, which is a plus. Are EGFR bispecifics reasonable options to pursue? Dr. Bhatia, what do you think? And what are the toxicities that are important to address with bispecifics, and what about the dosing and safety characteristics?
Yeah, so in this patient who has, again, PD-L1 positive disease, so thinking about all the inclusion criteria for our ongoing bispecific phase 3 trials, so we talked about 3 agents, all 3 are in first line or phase 3 trials. That's amivantamab, petosemtamab, and ficerafusp. They all enroll HPV negative patients with a PD-L1 CPS greater than 1 score. The only exception is petosemtamab here, which allows for HPV positive patients to enroll as well. So this patient would be eligible for any of those bispecific trials. It is obviously important to counsel them on the added side effects. So, if you were considering standard of care with either pembrolizumab monotherapy or pembro chemo, adding a bispecific adds a different set of side effects to these to their treatment. So typically all EGFR backbone drugs, which is all 3 of these, like we talked about, will cause some level of acneiform rash. There will be paronychia. There can be infusion-related reactions. So amivantamab probably has a very low risk of administration reaction because it's the sub-Q version of the drug that's being tested. Petosemtamab did seem to have a higher risk of infusion reaction. In its early phase trials, it was up to 35-38%. But with appropriate pre-medication, they were able to bring down that level of infusion reaction. And then ficerafusp, I don't recall having any or too significant an infusion reaction risk. So you want to counsel them on the mode of administration, the fact that AMI can be subcutaneously administered. Petosemtamab is an IV drug every 2 weeks. Ficerafusp is an IV drug every week. So kind of harking back to what Mithal said about the burden of appointments, the burden of frequent treatments. You have to counsel them on the frequency of administration and the added side effects with these drugs.
Thank you so much, Dr. Bhatia. All right, so some take-home thoughts. It's important that we discuss PD-L1 CPS scores. They can actually help us with making decisions on whether immunotherapy would be relevant to the patient's management. It's important to look at HPV status. That helps us with prognosis. The introduction of immunotherapy in the perioperative and adjuvant settings, we need to make sure that we're discussing this with our team members to ensure successful workflow. That includes our surgeons and our radiation oncologists. And we do need to follow up these patients longer term, since our immunotherapy is now stretching out for several months, in some cases a whole year, if we're looking at the Keynote 689 treatment plan. We need to be prepared for bispecific antibodies. These are going to start drifting into our treatment at some point, and it represents a new immunotherapy option being rapidly developed for head and neck carcinomas.
So that concludes our talk for tonight. We do have some time for some questions. So I think this is an interesting one and speaks to sometimes difficulty with coordination of care across, this large multi-D team. Mital, the question is, how should we coordinate with dental and ENT services before starting immunotherapy in patients receiving radiation to the oral cavity? What's your experience with this?
So luckily in the academic center that I'm in, most of our radiation oncologists per protocol will refer patients to dentists at the very beginning. So when they've met the patient for a consult, they'll refer the patient to dental school to make sure that they haven't got terrible dental disease before thinking about radiation. And even if they don't do radiation, patients benefit from having a full dental workup. But I know that this isn't the case in every academic center, and I think you were talking a little bit about your institution, that sometimes it's the MPs that end up referring patients to the dental school. Is that correct?
Yes, I mean, I think it's never, with dentists being so hard to come by, I think it's never too early to recommend a dental evaluation to this patient population. Given what we know about the demographics of this population, oftentimes these patients have not sought any health care in their entire life. So you can imagine what kind of shape their dentition is in. But they need that for radiation clearance. So when we think about pembro in the perioperative setting, the timing of when to do the dental eval is a little tricky because you don't necessarily know up front that they're going to need the adjuvant radiation. But you also don't want to give the 2 doses of pembro, have them send them to surgery, and then the dental evaluation and oral extractions be the reason why we can't start radiation within that recommended time frame. So it is tricky, and not everybody has the same resources. So you want to think ahead about that for sure, and counsel patients to make an appointment early. Do you want to choose the next question, Mital?
Yeah. So the next question I think we've already answered, but I'm just going to read it out anyway. What is the most challenging overlapping toxicity with IO and CRT to differentiate and treat in your experience? And I think it was mucositis, especially when it's further along the line of CRT. We really don't know whether it's coming from the radiation or the Keytruda. And that's been one of the most challenging overlapping toxicities.
This question's from the audience. I'll give this to Dr. Badia. Why is HPV negative a worse prognosis?
So HPV negative tumors arise in the context of field cancerization. It's primarily caused by extensive smoking and alcohol use. And these tumors tend to be, they tend to have more resistance kind of built into chemotherapy and to radiation. You can also be at risk of forming multiple primary tumors over a lifetime. So you cure one HPV-driven cancer, but the mucosa has a lot of dysplasia, which is precancerous conditions. And so they tend to keep forming these dysplastic lesions, multiple primaries, and tend to have larger primary tumors as well, which leads to chemo and radiation resistance. So there's a large degree of local regional recurrence burden with these patients even after you treat one primary tumor. And there's really only so much radiation or surgery that you can do in a tight head and neck compartment. So we run out of curative options quickly for these patients. They tend to have a higher risk of recurrence, frequent second primaries, third primaries, and it just becomes challenging after a while to treat them. In contrast, the HPV positive patients tend not to have substance exposure, at least those that are primarily HPV driven. So these patients have very low smoking exposure. Their mucosa is not damaged, not dysplastic. The tumors tend to be much more sensitive to chemo and radiation, and much more likely to be cured.
This one is also a good one. So who owns toxicity triage when immunotherapy is part of definitive therapy? How can we clarify responsibilities across surgery, medical oncology, and radiation oncology? So this is probably very maybe practice dependent, but I would say on the whole at Yale, medical oncology owns all toxicity management. I think it often will depend on where the comfort level lies. With chemoradiation, these patients are in a significant amount of pain, so opioids is almost always a part of the course, and good opioid or management, safe opioid management does not involve multiple people across multiple teams prescribing. So I think at least at Yale, we own most toxicity management, with the exception of skin. Dermatitis is often primarily managed by radiation oncology. But that may differ. I don't know if you have a different experience, Vital.
It usually gets turfed to us in medical oncology. I think it's because we know how to handle immunotoxicities, and radiation really doesn't deal with that. So, and we do like to sort of keep a careful check and taper off the steroids and see if the symptoms are disappearing. So,
I think they're seeing us more frequently too. They see the radiation oncologist once a week. Surgery pops in and out of care. They'll see them for the surgery, but then they may not see them again until when surveillance is needed. So I think medical oncology is more embedded and invested in these, the day-to-day. All right. Let me just check to see if there's one more question from the audience. Do we have time for that? Yeah, okay. So this question, is there any experience for addressing overlapping toxicity when using bispecifics with chemo or pembro? That's a good question. I think we have to draw from clinical trial experience.
Well, so bispecifics have not been combined with chemo yet, so that question hasn't arisen yet. And I think their side effect profile is quite distinct. Like if you think about cetuximab, that's the closest kind of example I can give you from standard treatment options. Cetuximab side effects are quite different from pembrolizumab side effects. So the rash, the acneiform appearance, the paronychia, the hand-foot rash, infusion reactions, all are much more common with EGFR targeting agents, including the newer bispecifics. So I think there's a little bit lesser overlap there than you see with chemo and radiation.
I'm going to take one last question.
Oh, yes. Go ahead.
I actually did type some questions probably ahead of time before. It's fine. So I just want to say this was a very good presentation. I like the format, and I love the slides. Very informative. I kind of have like a two-part question. So in our practice right now, it seems like there's been a pull away from encouraging patients to get PEG tubes. And so our patients are getting hospitalized because they're losing weight and are able to eat or drink. And so that's an issue. So I want to kind of know what your guys' what are you still encouraging? And then the second part is post-radiation. What I'm seeing is patients losing like the neck muscles and then they get stuck like this. And so do you guys have any programs or physical therapy that you're starting ahead of time? I recently started a survivorship clinic where I'm starting to focus on that and highlight doing posture exercises, but just kind of want to know, do your institutions have anything set up in place?
Yeah, so excellent questions. Your first question was Sorry, it's late and I haven't had dinner. The PEG tubes, yes, thank you. Okay, so this is a pretty controversial topic, I think, in head and neck cancer care. But in general, and at Yale, we do not put in prophylactic PEGs. But you have to be very vigilant, and it's early referrals to dietitian. It's daily, weekly counseling about the importance of caloric intake. It's involvement of speech, language, and pathology early and often to not only assess for any swallowing difficulties, but also, getting that swallowing exercise regimen going very early on for these patients to try to prevent the dysphagia. And then pain management is huge. We didn't have time to talk about all the ways that we can manage chemoradiation side effects. That's probably a whole nother talk in itself. But we start them on gabapentin before radiation even starts. I use opioids, week 2 or week 3, cautiously, but they're absolutely needed to get these patients through without, that significant weight loss that we see, and we still do see it, and we still do, when patients are approaching that 10% total body weight loss, we have the discussion about the need for a feeding tube. But what we know about putting feeding tubes in is that the risk of recovering function after a feeding tube is hard. Patients become reliant upon that, and the saying I always tell my patients: if you don't use it, you lose it. That's very true here. Your second question, remind me, was on neck fibrosis. Yeah. Okay. So that one, I think early referral to physical therapy is important. We have a patient education handout on neck exercises during radiation, and I'm happy to share my contact info after the talk, and I could definitely share that with you. It is Yale branded, but you could create something similar for your own institution. But making sure that patients are starting that exercise regimen even before we start therapy, and then counseling them. We see fibrosis weeks to months to years after treatment. So you have to, every time you see them when you're doing those survivorship visits, and say that's great, you're doing so well, and you have, your neck's moving well now, but I want you to be able to turn your head 5 years from now when I see you. So a lot of it is patient education.
And then my second question is for Dr. Bosky. I hope you don't mind me asking this. So while I did not go to ASCO, in Georgia we have GASCO, and so that's when we meet and and this is when I learned about the head and neck data. So I kind of have a question about one of our patients, 48 years old, have been having symptoms for more than 9 to 10 months, ended up going to the hospital, voice box gone, has a trait pretty much probably for life, got radiation resist cisplatin, and I'm wondering now with this new data, should he have gotten IO?
Well, it sounds like he's locally advanced stage, so still curable, no distant disease, correct? Yeah, so if you're doing chemoradiation, IO is not approved for pre-chemo radiation, it's only for pre-op. So you didn't miss out on any standard of care. But of course, close surveillance to rule out a recurrence, right? Or pick it up early.
All right. Well, that concludes our question and answers. Thanks for everyone for sticking with us tonight. Just a reminder to submit your post-test evaluation for the CME credit. The slides can be downloaded as well as the practice aids on the PeerView website. And stay tuned for the online activity based on this event. Thank you for joining us.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported through educational grants from Bristol Myers Squibb and Johnson & Johnson. To access all materials for this activity, visit peerview.com/RMT860.